Hello, I'm Gabriel Steg from Paris. I'm here at EuroPCR and I'm delighted to be joined by Tom Johnson and Julian Strange, both from Bristol Heart, to discuss multidisciplinary management of out-of-hospital cardiac arrests patients. And this is an extraordinarily important issue because it's very common, it's very lethal, and we are seeing an increasing number of patients survive from the out-of-hospital cardiac arrest to the hospital, and it creates all sorts of questions and issues. Why are we seeing an improved survival?
It's a good question. I think clearly the chain of survival, the awareness of the importance of early bystander CPR is something that is becoming increasingly apparent in the wider community. But what we understand is that actually in the community there is a real importance in terms of achieving as early as possible resuscitation. So CPR undertaken within the first 5 minutes of a cardiac arrest offers a mortality maybe of 50%. So still extraordinarily high, but there is a chance of survival. If CPR is delayed to 10 minutes, then there's an almost 0% survival rate. So clearly the importance of early awareness, acknowledgement, of calling for help and of starting to administer cardiopulmonary resuscitation is key to the success. And I think certainly the ambulance services, the wider community have bought into that idea, and we're seeing an increasing amount of successful resuscitation, return of spontaneous circulation achieved in the community. And then that obviously leads on to the delivery of these patients to secondary, tertiary care, which is where our involvement then begins.
So Julian, when these patients survive and make it to the hospital, the next question is what should be the pathway of care for these patients? And many of these patients may require angiography and potentially intervention. How do we select good candidates?
So I think we just focus on the comatose, intubated, ventilated patients, so we don't have a history from them. So we feel disempowered as cardiologists because we can't take a history from that patient and work out their comorbidity. So the ECG for ST elevation population is easy. They need to go to the cathlab. It's the non-ST elevation, abnormal or even normal ECG population that provides the real challenge for us. And it's trying to determine from that population who should have the input of a cardiologist or who shouldn't, and whether they should go to the cathlab or not.
And when?
And when. No, that's absolutely vital. The problem is, I think there's a very high hit rate for that population for having an acute coronary occlusion or significant underlying coronary disease or a cardiac cause for their underlying problem. So determining the population that goes to the cathlab, I think once you've excluded other major non-cardiac causes, my personal opinion is they probably should all go through to the cathlab at that point, and that allows you to determine the pathway of care for that patient. A set of normal coronary arteries helps out your intensivist just as much as us putting a stent in can, and it just determines where they're going to go.
Now, what is the data to support that angioplasty helps these patients? Do we have definitive data?
We don't have definitive data. That data has been collected at the moment. There's 5 randomized studies. They're basically looking at that exact population of non-ST elevation myocardial infarction and saying early or delayed coronary angiography and which is the best pathway for that patient, and trying to determine who would benefit most from that intervention. There is meta-analysis, there's non-randomized data. We have data in Bristol that seems to show a survival benefit if you have a lower threshold for taking those patients directly to the cathlab.
Now, in addition to being comatose, many of these patients on top of it will have shock and will require some hemodynamic support. So what is the current state of the art for hemodynamic support?
I mean, again, we're in the same scenario where there really isn't data to support the benefit of hemodynamic support. Balloon pump has been assessed, and clearly balloon pump isn't sufficient to provide hemodynamic support for these patients. There's been some work done on looking at other left ventricular support devices like Impella, and certainly Impella seems superior to balloon pump. But again, the data is very difficult to take very much from. And then beyond that, there's a consideration for maybe these patients being appropriate for ECMO. And really the greatest experience I would think for that would be Paris. That again opens up incredibly difficult questions about selection. So the need to really understand how we would administer such costly techniques and procedures in such a high mortality group. We have to be sure that we can appropriately select patients that might benefit. So if I understand correctly, ECMO, certainly out of hospital in Paris, is limited to patients under the age of 65, and there has to be an acknowledgement that they have had no downtime, that their resuscitation was commenced immediately on collapse, and that there has been very little in the way of potential neurological damage or other problems encountered during resuscitation. So it's going to be limited to a very small population of this overall group.
Now, I want to touch upon another issue. These are patients that die a lot. I mean, the mortality rate in these patients is enormous, and it has a major bearing on the outcomes of a given cath lab. And on top of it, the toll it takes on the personnel, the attrition for the team is an issue. How can we address that? How can we deal with that?
Julian's already alluded to the fact that we in Bristol have adopted quite an aggressive strategy for this, and that's on the back of a very successful primary angioplasty program. And it's partly due to the unique catchment that we live in, where we take a population of over 2 million out of hours. But it resulted in there being a number of patients that were delivered to us that had arrested in the context of their ST elevation infarct. We have seen a massive rise. I mean, over 100 patients in the last year or so undertaking this type of intervention with a 50% mortality, as we've discussed. The attrition on the cath lab team is immense, and that's something that we have to work into how we can actually run a successful pathway. The success of it also, though, relates to the pathway from point of entry, A&E, intensive care, through the cath lab, and ultimately actually to the psychological support of the patient in hospital and through to discharge and successful return to normal living.
Julian, I think as we come to a close, you have a message for interventionists and cardiologists alike on this population.
I mean, I think we have to, as a cardiology community, really engage with out-of-hospital cardiac arrest patients. We now are starting to develop the tools to help support, get better outcomes, improve survival, and it's really trying to get the data, getting us all enthusiastic about trying to help this very sick, very critically ill patient population, get them better and get them to survive more.
Yeah, this is truly a cardiology problem, not solely an interventional cardiology problem. Cardiologists have to be involved at the start, during the hospitalization, and when the patients go out of the ICU.
We had to become a little uncomfortable, communicate with our teams, emergency department, intensive care departments, and really work as a very cohesive body to get a good outcome for these patients.
Gentlemen, thank you. That was enlightening. I hope you enjoyed it.